Okay, in this section we're going to talk about labor, epidural, analgesia. And some of the topics we'll cover include the relative contraindications to LEA, the informed consent elements and risks of LEA, hemodynamic management and fetal distress, epidural pump and LEA management strategies in general. Now, for relative contraindications to LEA, one particular one is coagulopathies, especially including thrombocytopenia. Now, some studies have demonstrated that in patients with preeclampsia, even doing thromboelastogram studies, which is a very useful and physiologically appropriate measurement of how well a patient is clotting, that even with TEG studies, patients as low as 75,000 platelets in preeclamptics can still have a normal clotting profile. So one figure that's used by many anesthesia providers is the figure of 75,000 as a cutoff above which it's okay to put an epidural and have less risk of an epidural hematoma. So again, epidural hematoma is the primary concern with any kind of coagulation abnormality. Additionally, local infections in the skin or below, as well as systemic or blood infections evidenced by fever and other signs of bacteremia, are a potential relative contraindication to a labor epidural, because there's a concern that the epidural needle will go through an area with bacteria and deliver it to the epidural space, thereby causing an epidural abscess, which, similar to an epidural hematoma, is a space-occupying lesion and can be quite problematic in pressing on nerves and potentially even causing permanent nerve damage. Also, chronic back problems or surgery can be a relative contraindication that we will discuss in the next slide. Neuropathies as well can potentially be something that gives us pause. For example, multiple sclerosis or MS is a well-known example. And although the feeling with MS specifically is that stress can exacerbate MS, and so theoretically the epidural should be able to block the stress response the best and thereby actually reduce the likelihood of MS triggering. But the concern is there can be confusion between what the epidural potentially having caused a problem. This was especially true in the past where we had local anesthetics such as chloroprocaine and delivered on, in high volumes and in a concentrated location, as well as 5% lidocaine, which were neurotoxic. But now the local anesthetics that we use do not appear to be neurotoxic in the doses and volumes that we are using. But in general, it's a good idea to establish a good baseline of what their motor and sensory deficits are to make sure we demonstrate that we are not exacerbating the problem. But it's not very clear that local anesthetics will cause a worsening of the neuropathies when they're used judiciously. Another special case is if a patient has increased intracranial pressure manifested things like nausea, vomiting, blurry vision, photophobia, mental status changes, headache. Now we have to be careful, because if we go through the dura, going a little bit deep with the epidural needle, and spinal fluid leaks, there's a risk of brain herniation and potentially life-threatening shift in the brain through the foramen magnum as the pressure differential changes as a result of a spinal fluid leak. Now, for chronic back problems or a history of back surgery, we see this frequently enough, and so it's an issue that's worth addressing. One of the concerns with a history of back problems and surgery is that their entire spinal anatomy has a risk for having osseous growth or distortion in the anatomy, so epidural placement can be difficult in these types of patients. Additionally, the anatomic distortion of the spinal column can also result in patchy blocks where you have windows where the patient still has breakthrough pain connected to labor. A particular concern is if they have metal or hardware utilized in previous back surgeries in order to provide a fusion of certain vertebral levels. If the hardware were to be infected, again, because the epidural needle introduces bacteria from the skin level or below, or from the blood system to the epidural space, and it spreads to this hardware, that could potentially be a disaster if the hardware needs to be removed, which would be a very extensive surgery. Finally, also because of distortion of the anatomy, if we do end up getting a wet tap and the patient needs a blood patch to take care of this very difficult problem and source of great discomfort for the patient, then the blood patch itself may be difficult to place. And so there's another risk of a history of chronic back problems or surgery. Now, especially in the context of another very effective option, namely remifentanil PCAs, which we will discuss in a subsequent presentation, we have, in my mind, even a higher threshold for placing epidurals in patients where there may be difficulty, such as severe chronic back problems and a history of surgery in the lower back. And so given that we have that other option, namely remifentanil PCA, that can be used quite effectively, we should be careful about the types of patients that we place epidurals in. Now, specifically herniation of discs, discectomies, and laminectomies are not as problematic as are versus fusions of the lower vertebral spine, or the lower lumbar vertebrae, where there's bone fusion or fusion with hardware, then we again have this list of concerns that are much greater and give us pause in putting an epidural in. Now, one example of an informed consent is the following listing of issues that need to be presented. And the way I present it typically is to say, look, we're not trying to scare you. We place approximately 3 million epidurals every year in this country. And so with such a high utilization rate and such a high volume of experience, the chances are that if there were any major problems with epidurals, we would not have such a high volume of utilization. We would have discerned there to be a significant problem that would give us pause in utilizing this technique so frequently. So we're not trying to scare patients when we present all these risks, but informed consent means they need to be informed of what the risks are. And this in particular is true if the patient is on the borderline of whether they want to receive an epidural or they have some relative contraindications. Then these list of risks may be pertinent. And furthermore, the patient being aware of the risks and potential side effects and complications developing can give us early warning of problems that are developing so we can help take care of these. Now, one example of a side effect or risk that we need to discuss is the risk of hypotension. So epidural anesthetics can cause a drop in the blood pressure for a multitude of reasons that we'll discuss in greater detail later. And if the drop in cardiac output in particular is significant enough and the drop in blood pressure is significant enough, the mother will cause uterine artery vasoconstriction and sacrifice the perfusion of the placenta and the baby in order to preserve the blood pressure for the mom in preference. And the result is then a drop in oxygen delivery to the baby and potential worsening of the heart tones. And so epidural anesthetics can in fact be connected to fetal distress, especially in the first half hour after their placement.